Everyone, and welcome to Grand Rounds. Welcome to March. I'm very delighted to introduce our speaker for this morning, someone who's well known and respected by all, Dr. Sunny Dhanani. Dr. Dhanani received his degrees in pharmaceutical sciences and medicine from the University of British Columbia in 1998. He completed residency in pediatrics and his fellowship in pediatric critical care at the Hospital for Sick Children in Toronto in 2002, and did further training at the Great Ormond Street Children's Hospital in London. Dr. Dhanani is the chief of the pediatric ICU at CHIO and is as an associate professor in pediatrics at the University of Ottawa. He is chair of the Canadian Donation Physician Network and also chairs the National Disease Donation Advisory Committee of the Canadian Blood Services. He's an associate director of the Canadian Donation and Transplant Research Program. So lots of leadership work and expertise in this area. He's led international research pertaining to practices and standards for determining death after cardiac arrest for the purposes of donation. And this work has been recently published in New England Journal of Medicine, which is what we were all just giving him many kudos about, and very well-deserved work. The title of his presentation for this morning is When is Dead Really Dead? Findings of the Death Physiology and Prediction After Removal of Therapy, otherwise known as the DePPaRT study. Please join me in virtually welcoming Sunny Dhanani for Grand Rounds this morning. Go ahead, Sunny, it's all yours.
Thank you very much. I'd like to say, really appreciate the opportunity to speak. It is one of the first kind of forums to describe the study to people that weren't part of the research group. So this is really an important opportunity for me to get some feedback. You can, obviously the regular channels, but a call or an email afterward would really help on what resonated, what was difficult to understand would be really helpful for me. I think I'll broaden the topic a little bit to talk about organ donation in general a little bit just to start, so we have a context, and then really appreciate the findings of our study over the last couple of years. I have some disclosures in that I'm affiliated with a number of organizations that work for donation and transplantation, so I am biased, and I do have a small honorarium as the hospital donation physician at Trillium Gift of Life. So a bit of context. I should also mention, thanks for making this a Zoom thing. I actually get to wear a tie after maybe exactly a year as the pandemic hit us 1 year ago. So, I'm hopefully this is the start of something new. When we talk about organ donation in general, there's a couple of concepts that I think that the group would benefit from starting as a baseline. One is you can be a living donor, and that's kind of restricted to either a kidney, one kidney, because you can't live without both, or half liver. And this isn't actually very common because it's hard to find a match. There are systems called parent exchange where if your loved one needed a kidney and you weren't a match to your loved one, you could give your kidney to somebody in British Columbia, and their loved one might be a match for your loved one, and they would then close the circle with a donation to your loved one. And so this is increasing, but actually not that common. About 20% of donations happen this way. More commonly, and what we usually refer to as deceased organ donation, this is the slogan, one donor can save 8 lives. After death, the heart, both lungs, both kidneys, the liver can be split in 2, the pancreas, the small bowel can be donated. It actually isn't very common either. The process of deceased donation is an individual has to come to the intensive care unit with a catastrophic brain injury, and traditionally they're declared brain death or neurologic determination of death. This has very strict criteria, and it actually only accounts for 3% of all deaths in hospitals. That is not very common. So the opportunity to be a deceased donor actually is very low. Over the last 15 years, another opportunity for deceased donation has occurred, and that's called donation after circulatory death or cardiac death, DCD. And that occurs in the context of not being brain dead, but a decision that there's no hope for recovery in this catastrophic injury, that there's a consensual decision with the family to withdraw life-sustaining measures, then waiting for the circulation to stop, and then organ donation occurs. The difference between the two, I'll explain a little bit in detail, and we're going to focus on DCD a little bit. I do also want to mention tissue donation. In Ontario, tissue donation is on the rise. This refers to corneas, heart, valves, bone, skin, and others. It's not very common in kids, actually. One, because of the logistics. Actually, currently, tissue is organized independently and not provincially. And so most tissue organizations or tissue banks don't accept pediatric skin and bone. So we're left with heart valves, which we do here. So one thing to take home today is that organ donation is rare. So over the last 3 years, actually, there's only been 7 donors at CHEO. That's good in a way because our mortality rates are very low. In ICU, it's only about 2%, where in adults, mortality can be 30 to 40%. But what's important is that we have a system to optimize all potential donations to make sure we don't miss an opportunity. And in those 3 years, we notified Trillium 45 times. That's usually from the NICU, the PICU, and the ED where most deaths occur. 25 were ruled out right away because they were medically unsuitable, and 11 were approached. In fact, we tend to call all cases where we're discussing potential for brain death or potential for withdrawal of life-sustaining therapies. And in fact, in many of these cases, 7 of them actually survived. This is about not approaching all families, but not missing an opportunity to approach if it's going to happen. Now, 8 of those consented, and there were 7 actual donors. Again, there are a lot of calls that occur from the 5 pediatric hospitals in Ontario, but more than half of them are shut down right away, usually because they're not medically unsuitable. They're not suitable for donation because of disease process and the type of injuries and illnesses that pediatrics children have when they die, or there's no interest. I say that in bracket because there's always interest. It just may not be that there's a recipient that's appropriate at the time. Not all children can donate, and most of our deaths at CHEO actually occur in the NICU because of birth injuries and other anomalies, and many of those aren't suitable for transplant because of size. Kidneys, you need to be greater than 5 kilos, same with the liver. And most of this actually it has to do with technical issues. There are children that are this big waiting for an organ, but it's just very difficult to take the vasculature and excise and re-implant technically. Now, even though we had 7 donors, this resulted in 22 lives saved over those last couple of years. 7 hearts, lung donations, kidney recipients, the most common. And in fact, last year in 2020, despite being a pandemic and less donations, less transplants because we were worried about COVID, then in fact, there were 60 transplants in children here in Ontario, just in Ontario. Those are real lives saved every year because of process. There are still lots of kids waiting, lots of kids waiting. At the present time, this is last week's data, there are 25 kids. Not all of them are imminently pressing. Usually the kidney patients can live on dialysis for quite a while. But when we look at heart and liver and lung, there's time limitations there. Overall, not just in pediatrics, but one person dies every 3 days on the waiting list. And I think that's important to remember. CHEO has done a fantastic job supporting organ and tissue donation. We don't do transplants, but we take care of transplants. And almost 3 years running, we've won the award for routine notification. And again, I'll stress that it's not about whether they become a donor or consented donors or suitable to donation. It's whether we give people the opportunity for donation. I'm listing the current organ and tissue donation committee, representatives from all over the hospital. But most important, it's not about committees or policy awards, it's about people. And people here care about organ and tissue donation, and that's what makes this so valuable. And for me, a proud thing as part of my career path, actually. And really what we, again, reemphasize is that we don't want to miss opportunities to donate. So I want to focus in a little bit on this concept of DCD. About 15 years ago, the only way to be a deceased donor was if you were determined brain dead. But I think it was recognized that the opportunity for donation after withdrawal of life-sustaining therapies and in the situation where you weren't brain dead was leaving a lot of families without the opportunity to donate and a lot of transplant recipients without organs. And I think that the process really came to light when surgical techniques improved so that we could then remove organs from a body that had no circulation. For brain dead donation, the brain has been determined no blood flow, and so death is legally declarable, but the heart and circulation continues, so those organs are still being perfused. For DCD, that doesn't happen. We wait till the heart stops, circulation stops, those organs aren't being perfused, and then the organs are removed. And that created a technical issue for transplant recipients. But that was overcome about 15 years ago. And now donation after circulatory death has actually increased in Ontario significantly and been a big part of the rise in donation and transplant, especially here in Ontario. But what we recognize is that wasn't happening across the country. Other provinces, hospitals, physicians, and individuals weren't acknowledging this opportunity. Now, DCD can be controversial. I mentioned some of the differences, but end-of-life decision-making now becomes a little bit more subjective, or the optics of it. For brain death declaration, it's very objective. We go to a family, we say, we've met these criteria, your loved one has passed away, though the body is still circulating. Then we ask Trillium to come in and say, would you like to be a donor? Now we're going to a family with a subjective decision and we're saying we don't think there's hope for recovery. The optics of then going to ask for organ donation becomes tricky. And so is there a conflict of interest? We've mitigated this by separating those discussions. We've mitigated it by having discussions separated by time, by place, and in fact by person. We don't do the ask if we're an intensivist, giving so-called bad news discussion to then offer organ donation. We were worried about withdrawal of life-sustaining therapies and would we alter the practice if it was a DCD potential versus not? And the issue is that there's a window, as I mentioned, there's no blood flow to these organs. There's a window of how quickly the individual needs to pass away or die. A kidney can probably go without blood flow for about 2 hours. If from withdrawal to the time of death, it's 3, 4, 6 hours, then the opportunity to donate goes away and the surgical teams actually don't recover those organs. So the worry was, would we change our practice to hasten death in some way? Again, we're looking at standardizing practice so that doesn't happen. What I'd like to focus on today is the determination of death. We've never really thought about how we determine death from a circulatory perspective. And many doctors here on the Zoom call, I might ask you to reflect on how you learned to determine death. Was it listening to the heart? Was it feeling for a pulse? How long? Who taught you? Is it in a textbook? And maybe it didn't matter initially, but it does matter when we're talking about DCD, where the next step is organ recovery. And there's a lot of speculation and mistrust and misinformation about how we determine death. We see articles like this every day. Sometimes it's on the back page, sometimes it's on the front page. And in fact, there's been many special interest groups and people we respect, I'll say that in quote, with CBC presenting this a few years ago, that was really hard on our practices of determination of death, especially in the context of organ donation. Now, this is not a new mistrust. In fact, I'm wondering if many of you have seen things like this at a cemetery where there's a bell. Well, actually, the phrase "saved by the bell," some of you might even not get this reference, but "saved by the bell" actually comes from the cholera epidemic, where people were really worried that they were going to be buried alive, that the determination of death at the time and was just evolving. In fact, the stethoscope had just been evolved. They just figured out what a pulse was. They were really worried about being buried alive. And so the idea is not new, that there's mistrust in how we determine death. And when it comes to the context of organ donation, that becomes even more significant. It's not even just the public sphere. In the medical realms, there were publications with pretty significant and charged titles. Should we fear the reaper? Are organ donors after cardiac death really dead? So I think, we needed to make sure that we ensured trust in the system. I was, and our team were really worried about these stories that persisted about people coming back to life following the determination of death. And we recognized that many of the physicians that were worried about them had seen people come back to life, but maybe this was in the context of CPR and not in the context of withdrawal of life-sustaining therapies and in the context of organ donation. But we were worried that this was preventing the uptake of DCD across the country and internationally. What were the physicians worried about? Well, it's the fundamental principle that's called the dead donor rule, where you must be dead before donation occurs, and actually the donation process can't cause or expedite death. You can't take out the heart for donation while someone's still alive, even if they're in a withdrawal of life-sustaining therapy and it is anticipated that they will die. We have to wait for one to pass away before organ donation process can occur. And that's really important. There are legal definitions, but I think you might be surprised on how vague these are. So physician must be physically present to determine death. I'm surprised they had to put that down in writing. The death shall be determined by two physicians. In fact, in context, they added a second physician to add trust. They said that you have to have appropriate medical licensing. And then we had to make sure that the conflict of interest issue was ruled out, and that no individual who was part of the transplant team or knew the recipient significantly, clinically or otherwise, could be involved in the determination of death. But apart from that, and literally, this is the quote, determine death by accepted medical practice for donation. I think this is where the mistrust in the medical community was significant. What did that actually mean? In 2006, national guidelines, consensus guidelines, not based on evidence, tried to hone on that accepted medical practice and say, okay, in absence of palpable pulse, no blood pressure, no breathing, seen by the first physician, and then wait 5 minutes to determine death clinically with a second physician that confirms those criteria. I think that was an important step. And what we focused on was this 5-minute hands-off period, where between the first and second declaration, people felt that a 5-minute hands-off period to ensure death had occurred. Now, this 5-minute hands-off period actually became very controversial, because if you don't wait long enough, you risk violating the dead donor rule. And in 2008, there were 3 pediatric donations, cardiac donations, where they waited 3 minutes for the first one before removing the heart. And in fact, their ethics board, because it was under a research protocol, allowed them, or actually recommended they shorten the time to 75 seconds before removing the heart. People became very uncomfortable with that practice. And in fact, DCD stopped in many jurisdictions after that. If we wait too long, we risk deteriorating those organs. And some places waited 10, 15, 20 minutes before recovering organs. And we recognize that those livers and kidneys, lungs were not being perfused and ischemia set in, and they weren't transplantable. So we had to find this right time. And what were we looking for during this 5 minutes period? It's this concept called autoresuscitation, which is the spontaneous resumption of circulation. Now, this is a medicalized term, and it's unclear what whether I'm just making up that definition or not, and there's a lot of controversy about it itself. We get confused with a concept called Lazarus phenomena. Lazarus was, I believe, Jesus's second cousin who rose from the dead after 4 days, giving credence to Jesus is connection in the hand of God. Now, Lazarus phenomena is really related to the resumption of circulation in the context of CPR. And in fact, that's reported quite commonly, probably because we give drugs and we inflate thoracic pressures, we do CPR, and then we stop. And eventually those drugs get to the heart, or the reason, sometimes temperature normalizes and the heart restarts. But that's not what we're talking about here. We're talking about the resumption of circulation after withdrawal of life-sustaining therapies. And when we did a systematic review, we actually found that this doesn't occur. And when it is reported, it's case reports, and that it hadn't been documented significantly. And so we wanted to see if this was real. One, to identify whether this 5-minute window was appropriate, and two, to reinforce and reaffirm that that 5-minute window was okay, and that we might add trust in the system about the determination of death. And that's where this project, the Death Prediction and Physiology after removal of therapy study came from, that with some concepts, a lot of collaborators, we wanted to study the dying process scientifically to really reinforce the confidence when death is determined in this context. We were distressed again that organ donation wasn't being embraced across the country. Some people and some doctors were worried that people weren't dead before donating. Let me start by telling you a few things I'm proud of. One is our core team. These people, for me being a clinician and a researcher, to have people who were smart, collaborative, diverse, to organize the work we did over many years, I can't tell you enough how important this is for me. And I present this on behalf of them. Two, right from the beginning, we had family partner engagement. This is Heather Talbot. Her son died in 2009 in a traffic accident. Her son was a donor. We were connected through the Canadian Donation Transplant Research Program. She helped us build the study, affirm that it was okay to ask families to participate, that this was a question that was important to her. In fact, to be honest, she didn't even know that her son had been a DCD donor versus a brain dead donor. So she continues to be a strong member of our team, and we've even published as authors with her. Don and Patty Brinklow are also family members with us. I have a connection with Don as well. He was a goalie, and 10 years ago, there was a breakaway. He made the save, but collapsed on the ice. Lucky it was a firemen's hockey group. They did CPR for 45 minutes to resuscitate him, and he eventually had a heart transplant. He always tells me that he's so thankful and still a little surprised why he now loves chicken wings. And he's not sure if that's because he was resuscitated by firemen or that his donor apparently loved chicken wings. So it's so important to have the perspective of these individuals as we go through our research program. The co-investigators from a number of different countries and a number of different supporters, most prominently the Critical Care Trials Group and the CDTRP up at the top. These are smart people from bioethics, clinicians, researchers, lawyers, engineers that have helped us take this study to completion. What we were asking is to document the natural history of physiological function in the context of withdrawal of life-sustaining therapies. And we started with adults and pediatrics, but in fact, we didn't take hold at some of the pediatric hospitals. So it's just an adult study reported today. We wanted to determine the incidence of autoresuscitation reported by the healthcare team. And I won't talk about today, but to build a model to predict time to death. As I mentioned, there's that 2-hour window, and we wanted to see which patients were going to die within that 2-hour window. It was prospective, strictly observational. We didn't change any practices. We included all ICU patients who were dying, and that decision to withdraw life-sustaining therapy had been already made, whether they were a donor or not, and that they had monitoring. They had invasive art line monitoring, they had an ECG, they had a SAT monitor, and whatever else. We were very comfortable asking healthcare providers whether it was okay to ask families to participate in this study, and if the team felt no, we wouldn't ask them. That actually didn't happen very often, but we wanted to make sure that we weren't impacting the dying process. We were published in January, and we're really thankful for that. But again, I focus less on the top half and focus more on the bottom half. It's a big group of investigators, and the reason it's a big group is this was not an easy study to move forward. And without these people advocating for the question and the methods and the methodology, we wouldn't have done this. And it's not just them. Behind them were engineers, research coordinators. And so, you know, the success of the study it really depended on those. And I'm very grateful, humbly saying that we worked as a very good collaborative group. Let me talk to you about what we actually did, because it's really uncomfortable when you hear about it first. There's a decision in the ICU to withdraw life-sustaining therapies. That's on the left. There's an ask by the organ donation organization whether the family wants to proceed with donation, or there's a registered wish for that individual to be a donor. We then went in to consent for study. And in any context in ICU, it's a very charged, highly emotional environment. And for us to go in there and say, do you want to be part of research because we want to know how to determine death? I say off the cuff, is a hard ask. And in fact, at first people were very reluctant. But I think with a lot of collaboration, we went in and asked families. Then the act of withdrawal, usually it's to remove the ventilator and extubate to stop cardiac drugs like epinephrine. Then there's a period of time where the body starts to dwindle and then death is declared. Sometimes that's different from the actual moment of death, where physicians come in, you know, after a period, giving time and space to families, or because they're busy. And we collected a lot of data. Why people decided to withdraw, what were their initial illnesses, demographic data going into the study process, how withdrawal of life-sustaining therapies were done, what did they do first, was it a staggered approach? We then collected all interventions, how much morphine was given, what the settings were on the ventilator, how they stopped it, did everyone extubate? And we monitored waveforms and data from at least 15 minutes prior to 30 minutes after death was declared. And then we asked bedside teams, did they actually see resumption of circulation? And then we actually looked at the monitor going back from the time of death. So this was actually a pretty unique study, specifically because of when we were doing the study. It is the largest observation of its kind, and I'll just go through a couple of numbers. We had 20 sites, they were adults, CHIO being the 21st site, which we had a few patients that will sub-analyze later, and we are going forward with a pediatric study, hopefully over the coming year. These were sites in the Czech Republic and Netherlands. Most significantly, this is where DCD practice restarted. So it was really important to have them involved. 20 and then 16 sites across Canada. Even though this was an emotionally charged ask, 93% of families said yes to having their loved one participate in the study. I think that's a significant number when we usually find ICU study consents probably around 50%. We enrolled 631 adult patients in the cohort. And in fact, 67 of those were actual donors. So we actually enrolled not just donors because we felt the process of withdrawal of life-sustaining therapies and the determination of death probably weren't different between those two groups. And lastly, this probably took 13 years of our lives as a core team from the time we thought about the problem, created surveys, did our pilot studies, and then got ethics and funding to do this study to the time it was published. So let me show you some of the data. We asked the bedside team in those 631 events, did you see resumption of circulation? And in fact, in 13 cases, they did find it. Now, we weren't surprised by this because we had seen all those case reports when we did our systematic review. But what did they report? Actually, only 4 people reported that they had a resumption of both blood pressure and electrical activity. 6 of those people said they just saw a return of electrical activity. 2 people didn't comment on what they saw on the monitor, just said that the patient took a breath. And 1 person just said return of good waveforms. So in fact, this was consistent with what we were seeing in the reports. But what we wanted to do is take this one step further. Were we actually seeing cases? Was this actually resumption of circulation? And so we had developed this waveform viewer and what we called the beat browser to look beat to beat about whether there's electrical activity and blood pressure activity. You're going to see this a couple of times, so I'll orient you. The red line waveform is the blood pressure that's invasive. The green is the electrical activity of the heart. We won't focus on the stats, which is the purple. On the right side of your screen, you can see like an overview of the entire withdrawal and dying process. We need to identify when circulation stopped and when activity resumed. Something like this. You see the flat line, and then you see a resumption of circulation. The beat browser had basically in a single word, we use machine learning and artificial intelligence to identify resumptions of circulation. But because it was a sensitive study, we went ahead and got a group of experts from the scientific realm, from the clinical realm, and physiology realm to help us make sure we got this right. And what did we find in those 13 reports? Well, unfortunately, we lost signal in 2 of them. In 6 of the 13 reports, we actually recognized that it was just electrical activity, or the cessations weren't that long, that they were stops, but because people were looking for it, that they may have over-reported a resumption of circulation because it had only been about 30 seconds. And maybe that really wasn't a cessation to be able to call it a resumption of activity. But in 5 cases, we actually found that what they reported actually showed a stop in the blood pressure for at least 60 seconds, and then a reanimation or activity in the blood pressure and electrical activity. So we confirmed that in about 1% of cases, this actually does exist. You can see the times. Interestingly, 2 of these cases were actually in donation cases. And what had happened in those cases, the team restarted the clock so that they still waited the 5 minutes after the resumption. Now I can show you numbers, but I think it might be helpful to show you what we actually looked at. And this is one of those cases where the blood pressure is on top in red, the ECG is in the green. And we're going to go through a timeline. It's sped up a little bit, so because of, we can't do this in real time. But what you're going to see is the blood pressure eventually stopped. That's on top. There's often artifact, and that's what our adjudicators helped us identify, real or not. And these are not real. And then it started. This was a cessation of 2 minutes of 56 seconds before a blood pressure of a systolic of 75 recurred and lasted for 52 seconds. Let me show you that again. It stops. You can imagine that someone might say, hey, it's time to determine death. In donation, we would have waited the 5 minutes and seen this again and restarted the clock, which is what happened here. So this is really significant, and this is the first time we've scientifically documented what many of us have seen anecdotally, actually. And to confirm this, we took those 13 reported cases clinically that we corroborated only 5 of them and said, why don't we go back and look at all the waveforms we have? Now, we wanted to take a selection where we looked at all the waveforms that we had a full 30 minutes of recordings after determination of death. So it whittled our N down to about 480. And to determine death, we said that cessation of circulation or cardiac activity really is pulse pressure less than 5 millimeters, which we could zero down and zoom in where most people at the bedside couldn't. That lasted for about 60 seconds. And that was our adjudication team that helped us define this. And then a resumption of activity was anything, even 1 pulse, that was above 5 millimeters pulse pressure. And when we looked at the waveforms with that criteria, we actually found 67 patients that had 1 identified resumption of spontaneous cardiac activity. So I think this was a little surprising that 14% of the patients that we saw and we recorded waveforms actually had this phenomena of resumption of cardiac activity. I'll walk through the data a little bit so you see our whole spectrum. On the x-axis, we're going to look at the cessation of cardiac activity. How long was the gap? How long was the stop in activity? And you can see that most of them were within this 1 or 2 minute range. This is within those 67 patients, that the gap before resumption was only about 1 or 2 minutes. However, the longest one was 4 minutes and 20 seconds. This is important for us because we know for donation, we were waiting 5 minutes. So this moment was really important that it wasn't at 10 minutes. There were anecdotal reports of even 20 minutes, but we think those may not have corroborated if we had had waveform analysis of those episodes in previous literature. We didn't have any reports that long. On the y-axis, it's the duration of the resumption after the 1 or 2 minutes, or the longest one, 4 minute stop. How long did it last for? Again, at the bottom of the graph, most of them actually were 1 beat. Almost 80% of them were just 1 beat, and if anything, less than 5 seconds. The longest one actually lasted for 13 minutes before activity stopped for good. So again, it's really important for us to document this natural history, this variation in circulation and cessation of activity. There are lots of things that we found on top of this that are going to help us move forward, because we recognize that maybe people are seeing things and there might be errors in diagnostics when seeing resumption of activity or autoresuscitation. So when I look at this one, you can actually see blood pressure on top. The middle one is carbon dioxide, and all of a sudden the blood pressure stops. One might be fooled that there's absence of circulation here. But if we just wait a minute, and we actually knew there was still circulation carrying on, because in fact there was end-tidal CO2 production, which means you're circulating, that in the top row, you can see that the blood pressure waveform comes back. And what we think happened, if you can see the y-axis on the blood pressure, that when it went below a systolic of 50, the bedside team wasn't actually seeing the waveform, where we could go back and zoom in and change those parameters and have a look. So we think there's a lot to learn in how we determine death at the bedside to ensure safety of practice. Again, anecdotally, I think we recognize that blood pressure and function is different from activity that we see on the ECG. And there were 2 different things. And many jurisdictions actually continue to wait till the absence of electrical activity before moving for donation. And we can see in this, this view that the blood pressure stops. There was no artifact there, and the electrical activity actually continues. This electrical activity in this case continued for over 30 minutes without blood pressure. We feel that actually circulation has stopped, and this individual could be appropriately determined dead. And in fact, if we were waiting for electrical activity to stop without circulation, those organs for donation would unlikely be suitable for transplant. So this would be a missed opportunity. In fact, the electrical activity coincided with the last blood pressure only 19% of the time. So in fact, it was really common to have this separation between electrical activity and blood pressure activity. So running through the data, I hope that was a short journey that was interesting, that represented our most significant findings. But it's a good time to just take a pause and identify that really, though we're looking at numbers and we're looking at waveforms, and I'm describing to you a study that for us, I think what helped us through this and helped our healthcare teams and our researchers and our ethics boards move forward with a study like this is that we from day one remembered the individuals participating and the families that consented. That this was the most important part of our study, that we respected the dying process in the way we conducted the study and the way we reported the study. We learned a lot of things. That transient unassisted resumption of cardiac activity does occur. That this concept may be reported about 1% of the time, that in our cohort, we saw return of activity in 14% of our patients. Importantly, all our patients died. They didn't resume consciousness. This wasn't autoresuscitation in the sense of the Lazarus phenomenon, where people woke up and walk out of hospital. They all died. The concept of withdrawal life-sustaining therapies, confirmation and determination of death, protecting the dead donor rule, and moving to donation was respected. That there were cessations in activity that usually lasted 1 or 2 minutes long, and they only lasted for usually less than 5 seconds. And comforting was that our longest cessation was 4 minutes and 20 seconds. And that was important for us in that the current standard of 5-minute hands-off period in Canada was affirmed. We feel that we can add, our science can add to the practice of donation after circulatory death, that recommend that arterial blood pressure monitor is always there. And if not, we need other things like a cardiac echo. You can't just feel for a pulse in the context of DCD, that we need to scale the waveforms and be cognizant of that as you're at the bedside. That we should move away from looking at electrical activity and focus on cardiac function and blood pressure activity for the determination of death. And that if resumption of cardiac activity occurs, then we should restart the clock, because we know these resumptions are going to be really short and transient. Instead of stopping the DCD possibility altogether, which has happened when a resumption occurs, is to restart the clock and then carry on with the determination of death process and waiting 5 minutes again. Where do we go from here? So much data to look at. We're looking at withdrawal of life-sustaining therapies and how we do that and whether we should standardize that. We're looking at what drugs affect time to death. We're looking at predictive models on the time of death, whether someone is going to die within a 5-minute window or a 2-hour window. And we're also looking at how those organs are affected. One of the big questions I alluded to is, are we really worried about people's heart and circulation coming back? Or we're more worried about whether people are conscious during this donation process, whether they're actually going to come back to life. And we realize that this is more about the brain. And so we're doing a sub-study now and a further study to correlate the cessation of cardiac activity to the cessation of neurologic activity. That's hard to do. We're looking at EEGs, we're looking at transcranial Dopplers, we're eventually potentially going to look at MRI, functional MRI. And what we're finding is that actually neurologic activity stopped well before cardiac activity stopped. But maybe we should go further and see, what are those thresholds? Is it a blood pressure of 30 systolic? Is there a peak perfusion? Is it different within people? So lots of work there. We're applying to CIHR for further funding this spring. And we've already got some funding on something called a donation advisor. collaborative project between CHEO and the Ottawa Hospital, starting in Ontario. You can see a number of supporters where we're looking at trying to optimize the information for every potential donor. I'm going to go back to the phrase of no missed opportunities. Right now, 30% of patients going through a withdrawal of life-sustaining therapies and consent for donation actually don't become donors. So we're losing an opportunity for more than a third of families and individuals who wanted to be a donor, let alone who gets those organs and those missed opportunities. So we're trying to create systems and the science using a lot of clinical tools, the waveforms that we've done to try to predict who's going to be a donor. Then during the dying process, what's happening to those organs, what we call ischemic time and ischemic function, and then have a thorough donor assessment to allow individuals on the transplant teams to step up to the plate and offer organ donation to these individuals in the ICU. That project has started. We recruited our first patient in January at the hospital, at the Ottawa Hospital. This is without consent, but it was on the web. This sort of story occurs every week, where there's a tragedy. This young lady was 27 and hit by a bus, and they had a lot of questions. How did this happen? Was the bus driver drunk? Was there a way to save her in the critical care environment? Especially with COVID, they had no answers. And one of the things they were most upset about was that they wanted her to be a donor. They knew she was a donor, and the opportunity wasn't available for her. We don't know the details of that, but I'm hoping the donation advisor and the work we've done will offer families and individuals like this the opportunity to donate. There are 1,500 people on the waiting list, so that's important. I get it. Most of us are starting to register ourselves and have the conversation. 35%, a third of us are registered. Maybe that should be 50%. Maybe we should all think about it. And there are a lot of transplants. In the last 20 years, there's been over 20,000 transplants. But what I'm most proud of working in this field is last year in Ontario, there were 700 donors. These are families and individuals that have gone through the worst moments of their lives, children, families, adults, unrecoverable illness that were going to die, but they became donors. And I think that was important to those families. And so I'll end there, leaving lots of time for questions on donation process in general and the study in general, with a focus that I hope you take home, that high quality end of life is about including organ and tissue donation. But in fact, there's a lot of trust or mistrust there, and I'm hoping we can build the realm of the science of donation to help build the trust as we go forward. So thanks very much for your time.
Wow, thank you, Sunny. That was an amazing presentation of really phenomenal work. I think you really highlighted the whole issue of donation in general. I think that's a really important message for all of us to be thinking about. And then really being sure that you know, you're doing things right. Really phenomenal work. Congratulations to you and all of your team, and for the future successes that you're likely going to have, given what you've done so far and what you've mapped out going forward. We have, thank you for leaving us some time for questions. We have about 10 minutes for questions. If anybody wants to, they can either raise their hand. I'm just looking at the participant list. Looks like Hillary has a question. Go ahead, Hillary.
Thanks, Sunny. I actually have two questions. The first is, in those patients in whom you did see the art line resume, was there a clinical non-invasive correlate of that? You know, so was there a pulse palpated and or was there a non-invasive blood pressure determination done at the time? And
so because it,
question,
should I answer that first?
Yeah, go ahead. Yeah.
Yeah. So I wish, but you know, it was such a sensitive study at the beginning. Now it seems, oh yeah, we did it, and you know, we had lots of sites participate. At first, especially at the critical care trials group, we had respected members that I respect say, you are not coming into my ICU to do this. You are not keeping monitors on. And so we took a very observational approach. We said, we don't want to impact care. We don't want to impact your process. In fact, if you want to turn off the monitors, do so, and we'll collect the data remotely. And so we did not have the opportunity to say, can you just check a blood pressure or palpate? I think now that might be the study we'd want to do. We don't have to do it in that realm, or we could do it in DCD patients. We know consent rates are very high, that we want to correlate what we're seeing on an art line and what people see clinically. And I think that's really important. Maybe it takes us out of the realm of donation, but how we determine death in general and how we do resuscitation in general, to have those markers with our platform of being able to look at with waveforms. I think there's a lot of interesting information there in future work.
Yeah. My second question is, as you know, there are now in the world several countries in which it is the opt-out rule for donation rather than opt-in. And, just given the numbers of only 35% in Ontario who currently have consented to be donors, I'm just wondering, do you know what the state of those discussions are in Canada?
Yeah, I unfortunately had that in the talk, but didn't have time to put it in, and maybe I should present on it because it's a really excellent discussion from a bioethics and clinical perspective, and it's here. It's here in Canada. Nova Scotia has moved to a deemed consent model.
Okay. Yeah.
It's the first jurisdiction in North America. Our experience is really based on work done in the UK and Wales. And in fact, initially they found that this law of deemed consent or opt-out actually didn't make a difference. It didn't make a difference at all. But over time, it has made a difference. And why they think it made a difference is because actually it was the discussion that it created the infrastructure to say, actually, this is important. And to do this really kind of controversial thing, we actually have to make sure that people are educated, that every hospital has processes, that we have to have a coordinator to talk to families about deemed consent every time. And so all those infrastructure things were put in place. And so now, 3, 4, 5 years running, we're seeing in those areas, UK and Wales, that actually donation rates are skyrocketing and people are very comfortable with opt-out. And so I think what we should do in Canada is explore, and we're doing this scientifically, what was happening in Nova Scotia before, what they did to release opt-out, and what's going to happen after. And we're collecting that data and seeing if it's good for us as Canadians to offer that sort of legislation in Canada. So I'm really excited, again, that we're looking at the science of donation to make those decisions.
Thanks.
Great. Okay, we have a question from Sarah Lawrence.
Hi, Sandy. Fantastic presentation. So interesting. I'm wondering what the age of your youngest patients was, whether or not you had an age-dependent difference in this information, and whether you think this would apply to neonates.
Yeah, great 2 questions. I actually don't know offhand what my youngest patient was. I will look at that because I think it is important. Our oldest patient was in their 80s. We didn't see an age difference. We didn't see a gender difference. We didn't see a comorbidity difference. Where we did see a difference was in the methods of withdrawal. So there are basically 2 main approaches. Do you wean down the drugs and the oxygen and what we call the staggered approach? Or do you make a decision and extubate and stop all drugs all at once? And there was a difference in time to death and some cases of resumption of circulation. But we didn't see any other physiologic differences. For the neonate question specifically, I think anecdotally, you'd think, man, these are good hearts. They're strong, they're robust. I would hypothesize that this idea of separating electrical activity continuing for a long time and circulation absolutely fit with the neonatal population. But I'm not sure they're going to have much difference. But we had excluded those because we were worried that they might be different and skew our results. We're hoping as we go forward with a pediatric study that we will include neonates, at least some neonates that would be potential for donation. So the older, larger neonates to help us answer that question. Maybe I'll ask it back. Do you think with your expertise that we might find something different in the neonate?
I wonder if you would have that heart beating for a lot longer. I agree, these hearts are remarkably strong, and from my experience, they can go on after cessation of breathing anyways. We're not monitoring everything that you're monitoring, but you often will go back and hear that one little heartbeat every minute or two. You know, whether it's associated with a pulse or anything else, I don't know, but I would wonder if that 5 minutes doesn't apply to the newborn.
Yeah. So we'll have to explore whether people in the NICU environment and the families, you know, again, you know, such a emotional environment are ready to, I guess, add in those monitors. I think one of the reasons we had such a high consent rate was, thankfully, families don't do this every day. It was the healthcare team that said, listen, the monitor should come off and we shouldn't watch that and we should take the art line. Families at the bedside had never gone through this before. We're guiding them through this process. And when we said, listen, we'll keep the monitors on, they said, sure. In fact, it might have helped some of those families look at the monitor and see the finality of a flatline, you know? So great question, Sarah. Maybe we should have some more discussions moving forward. Love that.
Okay, I don't see any other question for now, Sandy. I'm wondering if you could just, you know, you presented a lot of really important information and lots of detail. I'm wondering if you could give us, you know, for the maybe for the frontline workers in different types of settings that may be encountering, you know, resuscitation that was not successful or doesn't look to be successful. What would you say are your, you know, main messages for all of us?
Yeah, I think that's a great question, and that's very helpful for me looking forward for future talks. I think in the context of the intensive care unit, I think recognizing that this is a natural phenomena and counseling families and bedside staff that you are going to see heart rates and blood pressure recur, that doesn't mean they're coming back to life. I think in that context, because it's a planned withdrawal of life-sustaining therapies, that expectation is really important, and guide everyone through this, you know, this horrible process. For other groups, say in Emerge, I think what I'd recommend is that this may occur as well. But in most situations in that environment, you're doing active CPR. You're expecting resumption of circulation. Mm-hmm. So I would say that give yourself time before you finalize the determination of death. Keep the monitors on so that you're not surprised by that last gasp. Again, as you say, we're so-called calling it and determination of death occurs, that be mindful of the same event, the recirculation, the reanimation of what's seen on the waveform. It does not necessarily mean that person is coming back to life. So preparing your team for that. What I've seen in the ED scenario sometimes is when the waveform comes back, everyone restarts CPR. And maybe that's not in the best interest of the patient. That maybe with this understanding in a different context, we might be able to say, oh, this is going to happen, but we're going to determine death after it stops. And it'll last 1 or 2 minutes, and then it'll stop for good. And I think so there will be, I think, a ripple effect of practice in other areas.
Great. Well, that is a great place to end there. Thank you, Sunny. That was a really amazing presentation, and congratulations again on all of your work.
Thanks
Bye.
for the opportunity, everyone, and always happy to take feedback on this topic. Thanks, everyone.
Bye, everyone.